Bronchiectasis is a condition characterized by irreversible and permanent dilatation of bronchioles and bronchi. It is mainly characterized by irreversible permanent dilatation of cartilage lining airways like bronchi and bronchioles. Coming to idiopathophysiology of this condition, etiology, the cause can be idiopathic or due to the conditions which predispose the patient to develop recurrent infections or due to the infections. So, following this infection, there will be inflammation in the airway. This causes destruction of smooth muscles and elastic tissue in the bronchial tree, causing the irreversible dilation of bronchiole. We'll see what are the causes that predispose to the development of recurrent infections. If the patient has genetic conditions like alpha-1 antitrypsin deficiency, cystic fibrosis, primary ciliary dyskinesia, and cartilaginous syndrome, in case of these two syndromes, there is impaired ciliary motility causing reduced defense, local defense, and also the pooling of secretions. This causes increased risk of infection. If the patient has bronchial obstruction secondary to foreign body causing obstruction or due to the tumor or lymph nodes causing obstruction, we have the Brock's syndrome, where the secondary lymphadenopathy causes a right middle lobe bronchiectasis due to the bronchial obstruction. And also, the stenosis can cause bronchial obstruction. Secondary to bronchial obstruction is called, it causes pooling of secretions and increases the risk for infections. The recurrent infections causes inflammation and damage. Then we have autoimmune condition called as Sjogren syndrome, where the secretions will be thick and tenacious. This causes the impaired clearance of the secretion and infections. The infections like pulmonary TB, measles, whooping cough, and bronchopulmonary aspergillosis can cause the inflammation in the airway. Inflammation in the airway, widespread inflammation, causes destruction of the airway, where the smooth muscles and elastic tissue of the bronchial tree is damaged. Along with it, due to the secretion of inflammatory mediators and cytokines, there will be goblet cell hyperplasia. This goblet cell hyperplasia causes increased secretion of mucus, which causes obstruction of the bronchiole. So there is dilation of bronchiole and ciliary motility is impaired due to inflammation. Again, the dilation of bronchioles and ciliary dyskinesia will cause pooling of secretions, increased risk of infection, and again it causes the infections, inflammatory damage, destruction, infection. It's a vicious cycle which causes progressive damage and permanent dilation of bronchiole. The clinical manifestation of this condition is cough. The cough seen here is severe, persistent, and chronic and productive. So, in morning time, the patient will have paroxysm of cough, which is due to the collection of the secretions in the bronchi when the patient sleeps. There is postural variation of cough, you know that. Then the sputum produced in this cough is copious amount, and it is foul smelling due to the anaerobic bacteria causing infection. The sputum, when it's left to stay inside the cup, it will have characteristically three layers, that is mucus layer, mucopurulent layer, and purulent layer. The patient can have hemoptysis due to rupture of thin-walled vessels in the dilated bronchioles. The hemoptysis is usually seen during infective exacerbation of bronchiectasis, where the amount of cough will be increased, and also the patient will have associated fever due to infections. The patient can have pleuritic chest pain. It is due to the secondary infection of pleura causing pleuritic chest pain, or due to the segmental collapse of the lung, which is due to the obstruction of bronchiole by the secretions. This causes pleuritic chest pain in some cases. Now, based on the type of dilation, we have three types of bronchiectasis: the tubular type, varicose or bulbous type, and cystic or saccular type. In tubular type, there is diffuse cylindrical dilation of the bronchioles. In varicose or bulbous type, the dilation will have indentations in between. This is called as varicose type, indentations in between. And then we have cystic or saccular type, where along with dilation, the dilated bronchiole will end in blind ending sac. This is called as saccular type. Based on the Type of dilation, we have three types: tubular, varicose, and cystic type. We have other variant of bronchiectasis where the patient will have non-productive cough, which is usually associated with TB, tuberculosis involving upper lobe of the lung, which is called as bronchiectasis sicca. On examination, general physical examination, the patient will have weight loss, fever, clubbing, and halitosis, that is bad breath, which may follow the after the cough of purulent secretions. On respiratory system examination, the patient can have nasal polyp and sinusitis. The nasal polyp and sinusitis can be secondary to the conditions we saw, genetic conditions we saw, there's Cartagena syndrome and cystic fibrosis causing nasal polyp and sinusitis, which we can see in subset of these patients. On auscultation, we hear wheezing due to the partial obstruction of bronchiole by the secretion and crackles. The copious amount of secretions inside the bronchioles can cause bilateral coarse leathery crepitations. These are the auscultation findings in these patients with bronchiectasis. The complications of bronchiectasis is cor pulmonale. That is secondary to this bronchiectasis, and some patients can have massive hemoptysis. The massive hemoptysis is due to the damage of bronchial epithelium and also due to the rupture of the thin blood vessels which are present in the dilated bronchioles, which is usually associated with bronchiectasis sicca. The patient can have secondary empyema, and also it can lead to formation of bronchopleural fistula, one of the complications of bronchiectasis. Then we have secondary amyloidosis as a complication of bronchiectasis. Now, how to manage these conditions? Condition bronchiectasis. Under investigation, we have chest X-ray. On chest X-ray, we can see honeycombing, which is nothing but the distal end of this dilated bronchioles. Here you can see the honeycombing. The cystic lesions, the dilated ends, blinded sacs can be seen on chest X-ray. The chest X-ray shows tram tract appearance, which are nothing but the longitudinal section of the dilated bronchioles. This is called as tram tract appearance. On doing HRCT will help to pick up even the slight abnormalities in the bronchioles, which is missed on chest X-ray. We will see signet ring sign and cystic dilation on HRCT. We can do bronchoscopy if we suspect foreign body or adenoma in the bronchioles. On pulmonary function test, we'll see both obstructive and restrictive component. Obstructive component because of the obstruction caused by secretions. The restrictive component is due to the repeated infections causing inflammation and lung parenchyma damage and fibrosis. Then we have treatment of this condition, bronchiectasis. The main therapy that is given in this treatment of bronchiectasis is airway clearance, where we give nebulized 7% hypotonic saline, the chest physiotherapy like postural drainage, and mucolytic administration. Airway clearance is very important in this patient. Then treatment of primary causes like obstruction. If the patient has obstruction, foreign bodies can be removed by bronchoscopy. If the patient has cystic fibrosis, we can give CFTR modulators like ivacaftor or lumacaftor. And we have to give antibiotic therapy in these patients. We can give penicillin antibiotics or macrolides like azithromycin and erythromycin. Azithromycin and erythromycin can be given for 6 to 9 months because they have immunomodulatory effect. In some patients with localized bronchiectasis, we can perform the resection of the dilated, abnormally dilated bronchioles. This is about bronchiectasis. To summarize, bronchiectasis is irreversibly permanent dilatation of cartilage containing airways like bronchi and bronchioles. Under etiology, we have idiopathic or conditions which predispose us to infections like genetic condition, alpha and antitrypsin deficiency, cystic fibrosis, primary ciliary dyskinesia, and Cartagena syndrome. The conditions causing bronchial obstruction like foreign body tumor and then lymphadenopathy stenosis, which predisposes for infection. The pulmonary infection like pulmonary TB, measles, whooping cough, and bronchopulmonary aspergillosis and Sjogren's syndrome will cause this bronchiectasis. Under bronchiectasis, due to repeated infections, we have inflammation. There is destruction of smooth muscles and elastic tissue lining the bronchioles. So there is abnormal dilatation of bronchiole along with ciliary dyskinesia. This will again predispose the patient for infection. The patient will have infection, inflammation, and dysfunction, and then destruction and dilatation of bronchioles. This is a vicious cycle. Then we have clinical manifestations. The patient will have cough, which is severe, persistent, chronic, productive cough. We have morning paroxysm, that is exacerbation in the morning, and the cough is postural variation. The sputum is copious, foul smelling, and has 3 layers. The patient can have hemoptysis in acute exacerbation of this disease due to infection. The patient can have pleuritic chest pain if the patient has pleura infection or segmental collapse. The types are tubular, varicose, and cystic based on based on the based on how the dilatation is. Then we have the examination findings of this condition, bronchiectasis. On general physical examination, the patient will have weight loss, fever, clubbing, and halitosis. Respiratory system examination, you can have on auscultation, you will have wheezing, crackles, and bilateral coarse leathery crepitations. Complications are corpulmonale, massive hemoptysis, emphysema, and secondary amyloidosis. On investigation, on chest X-ray, we can see cystic lesion, honeycombing, and tram-tack appearance. HRCT, we can pick up even slight abnormalities in the bronchioles. Bronchoscopy can be done if we suspect foreign body or adenoma. Pulmonary function test shows both obstructive and restrictive component. The treatment, mainly we have airway clearance by nebulized 7% hypertonic saline, chest physiotherapy, mucolytic administration, treatment of primary cause like obstruction by removal of foreign bodies, cystic fibrosis, CFTR modulators can be given if ivacaftor or lomacaftor, antibiotic therapy with penicillin or macrolides, azithromycin, erythromycin, which is given for 6 to 9 months, which have immunomodulatory effect. In case of localized bronchiectasis, the abnormally dilated bronchioles can be removed surgically. This about bronchiectasis. Thank you for listening.